Okay, our next speaker is Dr. Cara O'Neill from the Cure Sanfilippo Foundation. Title of her talk is Development of Consensus Guidelines for the Clinical Care of Individuals with Sanfilippo Syndrome.
Thank you. I'm honored to be able to share this work with you and the work of our wonderful team to develop these first consensus care guidelines for Sanfilippo. As you know, Sanfilippo is a multi-system metabolic disease characterized by the accumulation of toxic fragments of heparan sulfate. And while there are promising clinical trials underway, there are still no approved therapies. And until now, no published clinical guidelines. Not surprisingly, most healthcare professionals are not familiar with this disease. So when families receive the diagnosis of Sanfilippo for their child, they often feel a disconnect with the healthcare community that really has no idea what to tell them or information on how to guide their care. As such, the leaders of Cure Sanfilippo Foundation and Sanfilippo Children's Foundation recognized that the development of clinical guidelines could begin to change that narrative, even prior to the approval of disease-modifying therapies. Guidelines are important for many reasons, but some are increasing awareness of symptoms, promoting earlier and accurate diagnosis, and we also recognize that there is significant disparity in access to lysosomal disease specialists throughout the world, and by providing openly available guidance for clinicians and families, we can reduce the impact of those disparities and improve consistency of care regardless of geographic location. Families are further empowered by having this reliable information, and a one-stop reference can be a basis for policy changes and even more frequently impact healthcare coverage and reimbursement decisions. Additionally, guidelines help us highlight what we don't know and drive future research. This effort was guided by a few key tenets. One, it was essential to incorporate patient and family perspectives throughout the process. Two, we were focused on developing evidence-based recommendations that would be supplemented with clinical expertise. Because some areas are more understudied than others, we knew that we would have to rely more on clinical expertise in those sections. However, we thought that we could reduce potential bias by engaging a large and diverse group of experts across many specialties and countries. And lastly, due to heterogeneity among individual patients and disease subtypes, these general recommendations would need to be applied in a personalized manner in collaboration with each family. So I'll walk you through our process. We began by establishing a steering committee of 6 international experts, one who's on the stage with us, and representatives from 2 patient advocacy groups. We then performed a thorough literature review, and the resulting references were intended to serve as the evidence basis for subsequently derived guideline statements. Next, we added additional experts who were identified to be part of the guideline development group. This group was provided with the literature references relevant to their specialty and tasked with developing guidance statements informed by that or other known evidence and their clinical expertise as needed. The resultant 185 guideline statements were then input into an online survey platform and the link distributed by email to an extensive list of clinicians. As you see, there was a wide range of respondents from 21 specialty areas across 5 continents and with a high level of experience in the care of patients with Sanfilippo. Respondents were asked to indicate their level of agreement with each proposed guideline statement and were given the option to provide open text feedback regarding their responses. Agreement was captured on a 5-point Likert scale, going from strongly agree to strongly disagree, or they could opt for not my area of expertise. The commonly accepted threshold for consensus studies was used here as well and is defined as greater than 75% agreement, which in our case was indicated by responses of strongly agree or agree. So in survey round 1, most of the statements did reach consensus, but the 12 that did not were looked at more closely by the steering committee, particularly those that were near that consensus threshold. Those statements were revised, taking into consideration feedback from the survey participants. Those were sent out again to that same group of, that same email list of clinicians. And we had a very similar responder kind of makeup on that second round, and that resulted in 5 additional consensus-reaching statements. Combined with round 1, we were left with 178 statements for our final guidance recommendations that served as the basis of the manuscript. So what is in the guidelines? This is really a thorough discussion of the breadth of multisystemic disease impacts, importance of proactive monitoring, and various diagnostic considerations. Attention is also focused on the role of rehab therapies, patient and family support, and how to navigate specific challenging clinical scenarios. In the next few slides, I'll just show you a snapshot of a key table in the guidelines. This visually breaks down the timing of evaluations into 3 main categories for easy reference. Initially, those evaluations that should be done at or around the time of diagnosis for baseline, those that will be done on a periodicity schedule, and those that are done as clinically indicated. In the neurology section, you see here baseline cognitive testing and adaptive functioning, as well as MRI, and these can be important things for accessing services and getting children the supports they need, and MRI probably more so to refer back to when there are changes for the child or there are episodes of distress. So we'll come back to that in a minute. The next section I'll give you a sneak peek of is the nutrition and GI section. Here there is focus on eating, swallowing, and drinking, because the ability to eat by mouth is such an important aspect of quality of life for families. There's additional discussion on bowel function in the manuscript itself, which is also very important. And lastly, I'll show you the orthopedic section, which is often underappreciated in Sanfilippo syndrome, but does significantly impact quality of life for many patients. And you see here that we've encouraged clinicians to get baseline x-rays. This can be very important when you're later evaluating a child in distress to know if the abnormalities you see on a hip exam were just part of their original dysostosis or indicative of progressive disease and osteonecrosis. So that leads us right into this section, which is one of the most challenging clinical scenarios in Sanfilippo syndrome, and that is persistent distress. So this comment from the mother, "Help, I don't know what's going on, my child's been crying for weeks." And to give you a taste, it's something like this. If we can hear it. So by the time the parent gets to you, I can guarantee you they've racked their brain trying everything they can to figure out what's going on. And so when they get to you, they would really like for you to have a plan. We thought we would help clinicians out with this by providing kind of a checklist. And this is not in a particular order. Your history and physical exam would, of course, guide the order in which you went through these. Sorry. I'm a page behind you. So when a child has significant distress, it can be important to admit the child if you're not seeing an obvious, source of the pain, because it is very difficult for families to keep going back and forth to appointments with a child that is just miserable. So if you can conduct evaluations in an efficient manner as an inpatient, then that would reduce patient and family burden. So I'd like to show you a couple of real-world impacts in which these guidelines are already having a positive impact on families, and again, without any disease-modifying treatments. This young man is 12 years old. He had stabilized in his gross motor function and mobility and was released from physical therapy services because he was at a plateau, which in Sanfilippo syndrome is actually a wonderful thing if you can plateau and maintain your skills. Mom's a wonderful advocate, and she went through the process of petitioning to have this reinstated. Well, she was surprised to get a call one day that all of a sudden the problem had been solved and it was reinstated. She asked to understand what had changed, and in the reviewer's rationale, they included a quote from the clinical guidelines. So the family was very happy. In another instance, this mother is advocating for her child to have a one-on-one aide in school. She came armed with lots of paperwork, including the guidelines, and was surprised to find that the district had already went through the chain and got this approved, again, based on reference from the guidelines. Ongoing efforts for our team will be to develop a companion document in a user-friendly format, translated in multiple languages with our international advocacy partners so that we can increase access to this information. Additionally, we know that these will need to be updated periodically as therapies emerge. I'm going to hope that soon, and as clinical care evolves. And a gigantic thanks to everyone over the past number of years that we've been working on this project. We appreciate you all.